In this video, we are going to discuss about all the valvular heart disease in one go. Let's start with aortic stenosis. So aortic stenosis, we find concentric LVs, severe AS is defined at 40-4-1 rule. 40 means transvalvular pressure gradient more than 40 mm of Hg, peak velocity across the valve more than 4 meter per second, and valve surface area less than 1 centimeter square. Normal valve surface of aortic valve is 3 to 4 centimeter square. So symptoms are angina, syncope, dyspnea. Angina is due to increased myocardial oxygen demand due to left ventricular hypertrophy, and syncope is due to fixed cardiac output state that leads to decrease in cerebral perfusion, which leads to syncope. Dyspnea is due to increase in left ventricular end diastolic pressure that leads to increase in left atrial pressure that leads to increase in pulmonary capillary wedge pressure that leads to dyspnea. So after onset of angina, valve fluid replaced within 5 years, syncope 3 years, dyspnea 2 years. So here you find pulses parvus itatus, that is slow volume, slow rising pulse, and the pulse pressure is decreased because systolic blood pressure is decreasing in case of aortic stenosis due to left ventricular outflow tract obstruction. And here we find heaving effects. In case of severe AS, we find reverse split of S2, wide fixed split of S2 found in atrial septal defect, reverse split found in severe AS. So here we find S4. S4 is when the atria pushes blood against stiff non-compliant ventricle. Here in case of AS, there is concentric LVH, which makes the ventricle stiff and non-compliant, and the mitral valve should be not stenosed. That leads to production of S4. So we find here ejection systolic crescendo decrescendo murmur in the aortic area, that is the right second intercostal space, and it is a mixed frequency murmur, low frequency component, high frequency component. The high frequency component of the AS murmur radiates to apex. It is called Galaverdine phenomenon. So this is the murmur S1 S2. This is the systole. We find ejection systolic crescendo decrescendo murmur, systolic murmur, crescendo decrescendo murmur. So in case of mild AS, peak occurs earlier. When we are discussing about mild AS, this peak occurs earlier, and in case of severe AS, the peaks occur later. In case of mild AS, the peaks occur close to S1. In case of severe AS, peak occur far away from S1. So in severe AS, peaks occur later. In expiration, the murmur intensity increases because all the left side murmur intensity increases on expiration. On standing, murmur intensity decreases. All the valvular heart disease murmur decreases on standing because there will be decrease in preload, except HOCM and MVP. And they are exception to all these, opposite to all the valvular heart disease murmur. So on standing, there is decreased volume inside the left ventricle, or the preload is decreasing, that leads to decrease in intensity of all the murmurs. So except HOCM and MVP. In HOCM, volume decrease, smaller left ventricle cavity, interventricular septum and anterior mitral leaflet approximate more, that will create more obstruction to the left ventricular outflow. The obstruction worsens, and then that leads to increase in murmur intensity. Or squatting or passive leg raise test lead to increase in preload. When preload is increased, the murmur intensity of all valvular heart diseases increases, except HOCM and MVP, where the increase in left ventricular volume lead to large LV cavity, which leads to obstruction. Here you can see when there is less volume, the antral mitral leaflet and the septum are close to each other. When there is more volume inside the left ventricle, they are far away from each other. That leads to decrease in murmur intensity. In case of Valsalva, there is decreased preload. So in case of mitral valve prolapse, when there is low volume, there is kinking of this chordae tendineae, and the mitral leaflet is loose. But when there is more volume inside the left ventricle, these chordae are tight and they pull back the mitral leaflet down. So there will be less prolapse, and that lead to decrease in murmur intensity, or most commonly in mitral valve prolapse we discuss about murmur duration. So murmur duration will reduce. So on hand grip exercise, there is decrease in hand grip exercise, there is decrease in murmur intensity of AS aortic stenosis, because afterload is increasing. Now there will be less blood flow across the stenosed valve, that will lead to decrease in intensity of AS murmur. And recurrent murmur intensity increases in hand grip exercise, because when there is increased afterload, now the LV can't push the blood forward, it will push the blood backward. So the recurrent murmurs like MR and air intensity will increase. And here SVR is increasing in hand grip, aortic pressure is also increasing. In case of MVP and HOCM, when the aortic pressure rises, left ventricular pressure rises, left ventricular size increases, that leads to decreased obstruction, murmur intensity decreases. In case of MS, There is sympathetic shocks that lead to more flow across the valve when we are doing hand grip exercise. That leads to increased intensity of MS murmur on hand grip exercise. Inhalation of amyl nitrate leads to decrease in afterload, decrease in aortic pressure. That leads to increase in intensity of stenotic murmur like MS and AS, and decrease in intensity of rigor murmur like MR and AR, because there will be more forward flow. So in case of HOCM and mitral valve prolapse, when there is decrease in aortic pressure, left ventricular pressure will decrease, left ventricular cavity size will decrease. That lead to increase in murmur intensity. So now let's discuss about AR. So in AR, we find eccentric LVH dilatation with left ventricular dilatation. The thickness of ventricle is not increasing as much, but it is dilating. So in case of AR, we have a syndrome that is called aortitis, interstitial keratitis, and vestibulitis. That is called Cogan syndrome. In AS, we found Headache syndrome. Headache syndrome is AS with acquired von Willebrand disease and angiodysplasia of colon. And in case of severe AR, there will be left ventricular systolic dysfunction, increase in LVEDP, increase in LAP, in pulmonary capillary vessel lead to dyspnea. When there will be increase in LV preload, the afterload will increase. That will lead to increase in systolic blood pressure, decrease in diastolic blood pressure, because during diastole blood is flowing from aorta into the left ventricle due to rigor valve. That lead to widening of pulse pressure. When SBP increases, DBP decreases. That will lead to widened pulse pressure. So that will lead to forceful lateral expansion in systole and rapid collapse in diastole. So that will lead to some signs like light-out sign, that is due to the blanching of forehead with each heartbeat. Demusat sign is nodding of head with each heartbeat. Landolfi sign, change in pupil size with each heartbeat. Becker sign is visible retinal pulsation on fundoscopy. Molar sign is pulsation visible on uvula. Corrigan pulse is the dancing carotids. And main sign is decrease in diastolic blood pressure by 15 mmHg when one arm is raised. Hill sign is the surest sign, where the pressure difference between lower limb and upper limb is more than 20 mmHg. So Waterhammer pulse is found in case of AR. Quincke's sign, that will be blanching of the nail bed capillaries when we put light under it. That is also seen in case of AR. Rosenbach sign is visible pulsations on liver. Gerhardt sign is visible pulsation on spleen. Trop sign is pistol shot sound when stethoscope put over femoral artery. Durovic sign is murmur heard when we put stethoscope on femoral artery. Lincoln sign is nodding of leg due to prominent popliteal pulsations. Sherman sign is due to pulsation visible on dorsalis pedis artery. It is seen in more than 75%. So here we find collapsing pulse, pseudo collapsing pulse found in case of MR. It is rapid upstroke, rapid downstroke, ill sustained peak, and the volume is high. So pulses bispherians also found in case of AR. There will be two peaks during systole. One is percussion wave, tidal wave. In case of AR, the percussion wave is less than tidal wave or it is equal to tidal wave. But when the percussion wave is greater than tidal wave, it is in case of HOCM. There also we see pulses bispherians. So here we found hyperdynamic rocking motion of apex. We have found nocturnal angina, because when we are sipping there is bradycardia that leads to increase in duration of diastole. When there is more diastole, there will be more diastolic leak or backflow of blood from aorta into the left ventricle. From aorta, the carotid arteries rises. That will lead to less blood inside the carotid arteries, and that will lead to angina. So nocturnal angina seen in case of AR. Exercise make the patient better because it shortens the diastole. So strict BP control is required in case of AR. And vasodilator useful in chronic AR. Vasodilator useful in chronic AR. So because it will decrease the backward flow. When there the aortic pressure will decrease, there will be more forward flow, less backward flow. So vasodilator useful in chronic AR. So we find soft S1 and S2. If that is valve related issue, then S2 will be soft. If there is a root related issue, then S2 will be loud. So here we find early decreasing to diastolic, early diastolic decreasing to murmur, diastolic murmur, intensity is decreasing, decreasing. So we heard it in neo-aortic area, that is the third left intercostal space. It is high pitched murmur. AR murmur is high pitched murmur, blowing murmur. In case of severe AR, we find functional MS that lead to Austen-Flint murmur. In severe AR, there will be a jet of blood flowing from the aortic valve and strikes on the intermitral leaflet, that leads to closure of the mitral leaflet, and it reacts as functional MS. So that will lead to murmur of MS, that is mid diastolic murmur. So that is known as Austen-Flint murmur. But the MDM mid diastolic murmur in MS is associated with opening snap, but this Austin plate murmur, it has no opening snap and pre-systolic accentuation. So it is Austin plate murmur in case of severe AR. So mid diastolic murmur at apex. So on expiration, murmur intensity increases because it is left side murmur. On standing, valsalva murmur intensity decreases. On squatting or passive leg raise, murmur intensity increases. On hand grip, murmur intensity increases because there will be increase in backflow because it is regurgitant murmur. Regurgitant murmur intensity increases with hand grip. On amyl nitrate, the murmur intensity will decrease because it will lead to more forward flow. So 55-50 rule. So if the ejection fraction is less than 55% or left ventricular end systolic diameter is more than 50 mm, ejection fraction less than 55, left ventricular end systolic diameter more than 50, then we have to treat the patient. When it is asymptomatic, in symptomatic patient we have to do aortic valve replacement. In asymptomatic patient, if this rule 55-50 rule is followed, then we will do the treatment. So left ventricular end systolic volume, end systolic diameter more than 50 mm is due to LV dilatation. So now let's discuss about MS. So MS is American Heart Association classification. Normal valve surface is 4 to 6 cm square. Progressive MS is more than 1.5 cm square. Severe MS is 1 to 1.5, and very severe MS is less than 1 cm square. So first symptom is dyspnea. Dyspnea on exertion, because when we are doing exercise, there will be tachycardia that will lead to decrease in duration of cardiac cycle, that will shorten the diastole. When the diastole is shortened, there will be decrease in LV filling, that will lead to rise in LAP, which will lead to rise in pulmonary capillary pressure, that will lead to dyspnea. So beta blocker is used in its management because it will prevent from causing tachycardia. It will cause bradycardia. So in case of severe MS, increase in LAP, increase in pulmonary capillary pressure on long term, it will lead to pulmonary hypertension, vascular remodeling. That's called theory of second stenosis also. So pulmonary hypertension develop. So pulmonary arterial pressure rises. When pulmonary arterial pressure rises, now the right ventricle has to pump with more force. That will lead to right ventricular hypertrophy. That will lead to right ventricular dilatation. That will lead to tricuspid valve annular dilatation. That will lead to functional tear. So functional tear will be seen in case of MR. Due to pulmonary arterial hypertension, there will be loud and palpable P2. There will be prominent A wave due to RA has to contract with more force against the stiff ventricle, and V wave will be seen because there will be tricuspid regurgitation, backflow of blood during right ventricular systole in JVP. So theory of second stenosis will be seen in case of acute AR. I have discussed left it acute AR. Causes are aortic dissection, infective endocarditis, rupture of sinus of valsalva, and trauma. These are the causes of acute AR. So there will be sudden backflow of blood into left ventricle, so left ventricle cannot adapt it. That will lead to sudden rise in LVDP, and LAP rise will therefore then backflow of blood into the lungs. That will lead to frank pulmonary edema and dyspnea. Treatment is vasodilators before surgery. Ultimate goal treatment is surgery, but before surgery we have to keep the patient on vasodilator like nitroglycerin, nitroprusside. So in case of RVH, right ventricular hypertrophy, we hear parasternal heave. The 8 to 8 interval, it is the most important interval in assessing the severity of MS. So when there will be decrease in 8 to 8 interval, the MS is more severe. So TR murmur, tricuspid regurgitation murmur increases more with inspiration because it's right side murmur. It is called Caravallo sign. Shortening of 8 to 8 interval directly proportional to severity of MS. If a MS patient is on beta blocker, there will be bradycardia. So 8 to 8 interval will be increased. If a patient is on bradycardia, then 8 to 8 interval will increase. Isometric volumetric relaxation will increase. Diastole will increase because the diastole duration is increasing. There will be more duration of isovolumetric relaxation. So IVR is the time between 8 to and OS. So when the patient is on beta blocker, his 8 to OS interval will increase. But 8 to OS interval normally we assess that 8 to OS interval help us to assess the severity of MS. So shortening more the short 8 to OS interval, more severe is the MS. So long term RV failure can be there. When RV failure is there, there will be abdominal jugular reflex positive JPP rise more than 3 cm, about more than 15 seconds. So it is JPP abdominal jugular reflex positive. It is sign of impending right heart failure. In case of severe MS, there will be decrease in cardiac output, increase in left atrial pressure. It can lead to atrial fibrillation or atrial emboli. So when there will be LA enlargement in case of MS, that will compress the esophageal that will lead to dysphagia, and compress the laryngeal nerve that will lead to hoarseness. It is called Ortner syndrome. So you see mitral phases in case of MS. So pulse is normal, so low volume, and in severe MS the pulse is low volume. BP is normal. JVP we found A and V wave in long-term cases. Apex is tapping apex. It is laterally placed, and heart sound we found loud S1, loud palpable P2 due to pulmonary hypertension. S3, S4 are absent. So mid diastolic murmur with pre-systolic accentuation, and this is the mid diastolic murmur with the opening snap due to opening of mitral valves. Mid diastolic murmur with pre-systolic accentuation, rough rumbling and pre-systolic accentuation. It is not seen in case of mid diastolic murmur of Austin plate murmur. So it is associated with pulmonary regurgitation. Then we see Graham Still murmur. ECG we found if LA hypertrophy is there, then it is called P mitre. There will be bifid P wave on lead 2, and this will be the V1. The LA component is a lower component, it will increase. In case of LA hypertrophy, in case of atrial fibrillation, there will be absent P wave. Pulse will be irregular, short QRS complex, irregular RR interval, and fibrillatory waves on ECG. In case of right ventricular hypertrophy, there will be negative QRS on lead 1, positive QRS on lead AVF, and tall R waves in V1. In fact, R by S ratio in V1 is more than 1. So in case of RA, when the increase in RA size due to RVH, RA has to contract with more force. So RA hypertrophy will occur, that will lead to P pulmonal. The lead to the height of P wave will increase. In case of lead V1, the first component of it is due to RA, so first upper component will increase more. So due to stretching of left head border, we find splaining of carina. Splaining of carina means this angle will be more than 90 degree, will be obtuse. And due to LA hypertrophy, we will find double shadow sign on X-ray. So this is the findings we see in case of X-ray in case of MS. So let's discuss about MR. MR we need tight BP control because recurrent murmur will increase if there is increase in systemic vascular resistance or increase in afterload. So acute MR is due to papillary muscle rupture, postmetal papillary muscle rupture, because it has single blood cell, it is RCA in case of inferior MI. So due to chorda rupture in case of infective endocarditis, treatment is acutely we have to give vasodilators that would decrease the afterload and decrease the regurgitation. So here the murmur is heard short decrease endosystolic murmur. Primary MR is due to organic MR in leaflet or chorda issue. Rheumatic heart disease, mitral valve prolapse. Rheumatic heart disease is most common MR in developing countries, MVP in developed countries. So in case secondary MR due to functional MR, there will be hypertrophy that will lead to dilatation of left ventricle, lead to systolic entry motion of mitral leaflet, that is in case of hypertrophic cardiomyopathy. So in secondary MR we see MR begets MR, LV dysfunction, annular dilatation, functional MR, that will again lead to LV dysfunction, annular dilation. So this vicious cycle will continue. It is called MR begets MR. There will be volume overload in case of MR. So eccentric hypertrophy with dilatation, there will be LV failure, decompensated. Soft S1 will be there in case of MR because coaptation zone is not formed properly. Increase in LV EDP due to LV failure. Diastolic failure will be there, LV LDP due to LAP and dyspnea. Ejection fraction will decrease eventually. There will be pseudo collapsing pulse, rapid downstroke with well sustained peak and normal volume. LV failure, there will be decrease in systolic blood pressure, pulse pressure will decrease. So giant V wave seen in JVP in case of TR. So rapid wide descent in case of TR. So there will be wide split of S2, early A2, because there is less volume inside the left ventricle. So A2 will be early, P2 will be as usual late. So there will be wide split of S2 because of LV blood during systole, decreased volume. So A2 will close early. So S3 is due to sound of failing heart. So rapid filling of volume overloaded LV with extra blood. Severe MR, there will be LV failure and there will hurt the S3. So S4 will be absent, S4 will be end of AS. So S4 is when atria contracts against non-compliant stiff ventricle. In case of AS, LV hypertrophy, pansystolic murmur. So in case of AR, we heard the pansystolic murmur. It is high frequency in mitral valve. It is mitral valve regurgitation is symptomatic or asymptomatic. We do mitral valve replacement in all the symptomatic patient. In case of asymptomatic patient, we follow the 60-40 rule. 60-40 rule standard: left ventricular ejection fraction less than 60% or left ventricular end-stage diameter more than 40 mm. Then we will do the valve replacement. Increase in diameter of left ventricle at the end of diastole. In chronic MR, LV dilates that lead to LV dysfunction. LV EDD, left ventricular end diastolic diameter at the end of diastole. Largest LV size, LV end systolic diameter. Smallest LV size. Post mitral valve replacement, there will be sudden increase in afterload that can lead to LV failure. So in case of acute MR, sudden jet from LV to non-compliant LA, that will lead to increase in LAP. Decrease in pulmonary capillary that will lead to dyspnea. Severe acute MR, increase volume overload into LA, that will lead to decrease in cardiac output. Cardiogenic shock, cold calming extremities, decrease urine output, low BP will be there. They are the forward symptom. Backward symptoms are dyspnea and frank pulmonary edema can be there. So treatment of hypertrophic cardiomyopathy is septal myomectomy, beta blocker or calcium channel blocker or disopyramide class 1A antiarrhythmic. So now let's discuss about mitral valve prolapse. Most commonly posterior leaflet undergoes prolapse. So excess odorant and valve tissue bulges into left atrium, stretching of papillary muscle that will lead to myocardial stretching. Symptoms of ischemia like chest pain it will present as. So MVP has to do with non-ejection click, and ejection click is due to opening of pulmonary valve or aortic valve. Non-ejection click is seen during systole. It is due to mitral valve prolapse due to stretching of the chordae. So murmur, mid diastolic crescendo decrescendo murmur, mid systolic crescendo decrescendo murmur, heard in case of mitral valve prolapse. Mid systolic crescendo decrescendo murmur. So radiate anterior mitral leaflet if is involved, the murmur radiates to axilla. If posterior mitral leaflet is involved, it radiates to aortic area. So this is the murmur. Mid systolic crescendo decrescendo murmur. It is the non-ejection click or mid systolic click. Here you can see here when the click moves closer to S1, then the murmur duration will increase. When there will be less blood inside the left ventricle, then the click moves closer to S1, that will lead to increase in duration of the murmur. So murmur duration increases on valsalva starting, where there is less volume inside the left ventricle. Longer duration of murmur duration decreases on squatting and passive leg rest test. Click moves away from S1, there will be shorter murmur. Here you can see click is moving away from the S1. In case of hypertrophic cardiomyopathy, we found broken broke phenomenon, paradoxical fall in aortic pressure after a premature ventricular complex, and here we find systolic motion of anterior mitral leaflet after anterior two-third of systole. AML is shocked into the due to asymmetric septal hypertrophy. There will be systolic motion of anterior leaflet. LVOT also obstruction becomes more worse because this AML and the septum create more obstruction. So obstruction of LVOT will lead to ejection systolic murmur at lower left renal border, and there will be functional MR that will lead to pansystolic murmur at apex. So S1 will be normal, S2 will be reverse split due to LVH. It has more time to eject blood, so A2 will move in front of P2, so there will be reverse split. So S3 will be present in rapid filling against non-compliant LVH. There will be S4 will be present. S3 due to failing heart. For S4 the valve has to be normal and the ventricle have to be steep. In the valve I mean mitral valve. So good for patient is increase preload, you have to increase hydration, increase afterload, hand grip exercise. Heart rate should be low physical activity. When there is increased preload, the volume is more inside the left ventricle, so there will be less obstruction. Increase in afterload lead to more volume inside the left ventricle, that lead to less obstruction, and increase heart rate lead to increased duration of diastole, that will decrease in heart rate lead to increased duration of diastole, that will lead to less obstruction. For if there is more contraction, there will be more obstruction, so avoid digoxin or inotropes like that only. Murmur intensity decreases on hand grip after afterload, and murmur intensity decreases with hand grip exercise due to increase in afterload, or giving phenylephrine, that will also increase the afterload. So this is all about the valvular heart disease. So let us discuss some other points. So in case of mitral stenosis, we found malar flush, pinch flush, blue faces, it is called mitral faces, decreased cardiac output and increased pulmonary arterial hypertension leads to retention of CO2 vasodilatation. There will be precordial balls also. This is the inspector finding. On palpation, there will be parasternal lift, palpable P2, diastolic thrill. Parasternal lift is due to annular right ventricle, palpable P2 due to pulmonary hypertension, diastolic thrill is due to increased intensity of murmur. Loud S1 will be there in case of auscultation in MS, seen in initial stages of mitral valve is flexible. Opening snap will be there in auscultation. It is caused due to sudden opening of thickened leaflet. It follows the A2. As the disease progresses, the duration of A2 and OS interval decreases. It is best audible at the apex of the diaphragm of the stethoscope. So diastolic murmur will be heard also here. Low pitched top rumbling murmur with the bell of the stethoscope. It follows the opening snap, best order at the apex, lower left lateral recumbent position. When it is loud, it may radiate to axilla. The duration of murmur correlated with the severity of stenosis. The duration of murmur correlated with severity. We assess the severity by the A2 interval in case of MS. So there will be loud A2, pulmonary hypertension causes loud A2. There will be pansystolic murmur, others caused by pansystolic murmur due to functional tricuspid regurgitation. Graham still murmur is a diastolic murmur due to pulmonary regurgitation in case of MS, caused due to dilatation of pulmonary valve ring in case of severe pulmonary hypertension. So in case of severe pulmonary hypertension, there will be dilatation of pulmonary valve ring that will cause pulmonary regurgitation and relate to Graham still murmur. It is in case of severe MS. So prominent AOF and JVP due to atrial systole. So tall peaked P waves due to right atrial enlargement, right axis deviation will there due to right ventricular hypertrophy. So mitral valvotomy is indicated in symptomatic NIH functional class 1, 2 to 4 patient. Mitral stenosis with orifice less than 1 centimeter square, normal size less than on normal size adults, or less than 1 centimeter square body surface area. So in case of mitral stenosis, treatment is administration of warfarin in the patient with MS who develop atrial fibrillation because it increases the risk of clot formation. Surgical mitral valvotomy, mitral valve replacement. Mitral valvotomy is done. It is done in symptomatic patient whose mitral orifice less than 1.5 centimeter square. It can be either percutaneous mitral valvotomy or open surgical valvotomy. Mitral valve replacement is done in patient whose mitral valve is severely distorted. Severity of mitral regurgitation can be assessed by wide splitting of S2 due to regurgitation of blood pressure in the left ventricle fast rapidly leading to the early closure of aortic valve that leads to early A2 and late P2 that causes wide splitting of S2. So severity of mitral regurgitation can be assessed by wide splitting of S2. Clinical finding indicates severity of MR, reduced cardiac output, palpable systole E3, palpable S3, wide splitting of S2. Note the intensity of murmur not always correlated with the severity of murmur. So intensity may be decreased in severe MR caused by LV dysfunction or acute periprosthetic valve regurgitation. Features of severe aortic stenosis are pulses, parvocitatus, palpable carotid thrill, louder or late picking of the systolic murmur, single S2 or paradoxical splitting of S2. So presence of S3 or S4 heart sound, signs of right or left heart ventricular failure, left ventricular hypertrophy. So these are the phonocardiograms of murmurs. So this is the normal S1, S2, systole, diastole in the aortic stenosis, the ejection systolic crescendo, decrescendo murmur, mitral regurgitation, pansystolic murmur, aortic regurgitation, early diastolic decrescendo murmur, mitral stenosis, opening snap with mid diastolic murmur with pre-systolic accentuation, and loud S1. And in case of patent ductal saturations, there will be continuous masonry murmur. Barlow syndrome refers to mitral valve prolapse. Mitral valve prolapse syndrome is also called systolic click murmur syndrome, Barlow syndrome, or floppy valve syndrome. It is the most common abnormality leading to primary mitral regurgitation. It is the most common cause of MR in developing countries also. So note infantile scurvy is referred as Barlow's disease and Barlow's syndrome is mitral valve prolapse.